We'll get started with our first speaker then right away. I would invite Dr. Amir Kazory to come up and speak to us about chloride in acute heart failure.
Good morning, everyone. My name is Amir Kazory. I'm from University of Florida. For the next 15 minutes, I'm going to talk about chloride in heart failure. I would like to thank the organizers of this meeting and Professor Mehta for giving me the opportunity, as well as the moderators of this session. Okay. These are my disclosures. None of them is directly related to the talk I am providing today. We are living a sodium-centric world. You are an intensivist, cardiologist, nephrologist, we are the same. And I know that some of you have been in the symposium half an hour ago. You were thinking, this guy is such a hypocrite. He was just telling us about the importance of sodium. But give me a few minutes. Observation number one. Let's go through 3 observations together and see how you feel about it. Observation number one is that on the x-axis, you see the serum sodium, and on the y-axis, you see 3-year mortality. All of us agree with it. The lower our sodium, the higher the mortality, right? Lower sodium, higher mortality. It's not really rocket science. However, if you come back and correct this hyponatremia in patients with heart failure, 2-3 major trials actually about 15 years ago, they all came back negative. You don't improve the mortality. What happened? Maybe we didn't look at the subgroup that had hyponatremia, not all the heart failure patients. Yes, we increased their sodium, but no, there was no difference in mortality, whether we are hyponatremic or not. Observation number 2. If you go and ask a cardiologist, I want one advice for my heart failure patient, they say low sodium. This is the number one, what we call self-care behavior recommended to patients with heart failure. All the associations, no matter what they deal with, they take it on themselves to come and give us some advice on sodium consumption, okay? However, a couple years ago, a major study in JAMA looked at 2,600 studies. They found less than 10 studies that well done in the area of sodium consumption and heart failure. And guess what? All of them had less than 100 patients, and the majority of them didn't show any benefit. Think about it, sodium consumption in heart failure. And not only that, there are studies like this one that show if actually you decrease the sodium consumption, you worsen the outcome. On the left side, you will see the death or hospitalization, and the red line is patients who had less than 2.5 grams per day of sodium, around 100, 110 millimole of sodium, right? So on the right side is heart failure. So the point is, not only you don't improve much, you might actually hurt them by telling them not take any sodium. So there are some groups that come and say, this is American College of Cardiology, and say, hey, maybe too little sodium is really bad. 2 observations so far. The third one, a patient comes with acute decompensated heart failure, fluid overload, congestion, huffing and puffing, and you say, I am going to give this patient hypertonic saline. I'm going to give this patient a lot of salt. Would it make sense? It does make sense, actually. There are studies that have been done. This is the American one and then you will see, let's say next slide, you will see that urine output goes up and weight goes down. So you give them hypertonic saline plus high-dose loop diuretic. You improve their congestion by giving them sodium. 3 observations. I hope I started to make you think that maybe it's not all about sodium. But believe it or not, thinking that salt is not all about sodium, you think this is trivial, but it was only 2015 that the first study came out to question our current sodium-centric view. Here, Justin Gordon from Cleveland Clinic looked at the patient's chloride on admission. They showed that the lower my chloride, the worse is my survival. This is how they looked, and they looked at how many patients? 1,300 patients. What was interesting was that when they looked at the chloride and sodium, they saw that low chloride is bad no matter what my serum sodium is, meaning that the driver of outcome seems to be the chloride, not the sodium. Down, I put low chloride for them, whether the sodium is high or not, they have worse outcomes compared to the other two. Well, this was in acute decompensated heart failure. What about the chronic heart failure? 1 year later, he himself did another study in chronic heart failure patients. Again, the same trend is there. My chloride is low, my mortality is high. That's as easy as this. But is it again sodium or not? First of all, they looked and said, hey, you adjust for all kinds of confounders, and then still it is there. Between 26 to 29% increase in 5-year mortality when my sodium is low, okay? When you look at the serum sodium and serum chloride, you see the same exact pattern. Low chloride is bad, whether your sodium is normal or not. The driver of the outcome is serum chloride in patients with heart failure. So should I go on and on? This is 2016. I just show you one thing. You remember the magic trial that at the beginning I showed you, the lower my sodium, the higher my mortality. They did the same actually diagram. They have the same pattern. The lower my sodium, the higher my mortality. This time, they looked at the chloride also. When adjusted for chloride, this association faded away. So maybe we have been looking at something wrong. We never adjusted it for chloride. That was the question. But is it only in Cleveland Clinic in US? No, here it is in Europe, Great Britain. The same thing. Actually, they looked at both groups of heart failure with reduced or preserved ejection fraction. Same pattern. Low chloride is bad no matter what your sodium is. China, same way. Now they've started to just reproduce the same concept over and over again, several studies. So we did a meta-analysis. We looked at the same thing. Obviously, the same pattern came out. Chloride is the main determinant of outcome in patients with heart failure. Okay. So far, I have told you, let's not be so sodium-centric. Then I offered an explanation. Then you're asking yourself, where is the biological plausibility? You showed me some statistical numbers. Now tell me, is it real? How can that happen, basically? I would tell you there are at least two mechanisms that chloride might be having this effect on the kidney. Number one is that it might just have something with the neurohormonal activation that we always want to actually block in patients with heart failure, meaning that it increases renin secretion. Number two is that it might have something to do with the targets of diuretic therapy. It doesn't allow our diuretic to work as well as we hope. I'm not going through the details, but this is the chloride in macula densa, at least through one mechanism, which is the COX-2. We know that it increases the renin secretion. Probably also you will see on the top one through the adenosine as well. So whether they are working or not, at least there is biological plausibility to it. It's not just the statistical equation. The other one is, again, I don't go through the details, whether you look at the NCC in the loop of Henle, or NKCC, or you look at the NCC in the distal tubule, you will see that if I have low chloride, I will have suboptimal response to the diuretic that is working on that transporter. This is as easy as this. So it might just hinder our possibility for decongestion, basically. So I told you sodium-centric, being sodium-centric might not be that great. Chloride might be good. Then I provided some biological plausibility. The last stop, probably the most important one is, okay, if you are saying so, by increasing chloride, you should improve the outcome, right? That would be the next, I would say, reasonable step. Okay, let's take a look at this. We can increase serum chloride by two mechanisms. One is just giving them sodium-free chloride. We give them chloride and we see what happens. Number two is we give them a medicine and we increase serum chloride and see what happens. Giving sodium-free chloride supplementation is really at its infancy. This study admitted 10 patients. And you would ask yourself, 10 patients published in Circulation? Yes, because it was the second part of a bigger study. So basically, they looked at the supplementation of chloride, and they didn't see much improvement in terms of their renin. Actually, if anything, renin went up, and they were not really sure what is going on. And when they looked at other measures of markers of congestion, they reported improvement. But when you see me putting arrows to tell you if it is going up or down, you will see that the effect has been modest, probably. Okay? So far it seems it might or might not work. It is not against our what we thought, but it doesn't seem to be really promising. We should wait for more studies, which is coming. I'm going to show it. What about acetazolamide? Acetazolamide, we all know it. It gives us hyperchloremia. It increases serum chloride at the cost of bringing down the bicarbonate. We use it in metabolic alkalosis, right? Okay. There is a study, diuresis heart failure. It was a pilot study. I'm not going to talk about it in the interest of time. I go to ADVAR trial. It was published in New England Journal of Medicine a year and a half ago. What it showed was that when you add acetazolamide to loop diuretics, you increase serum chloride, you improve decongestion quite a bit. They decrease the length of stay and improve the decongestion both on day 3 and at discharge. So it continues. Tachyphylaxis is not a problem, it seems. Shows the same concept, cumulative urine volume, cumulative urine sodium. Both of them are going up when we are using acetazolamide. It is another way of showing it. I just want to mention that it is statistically significant. There have been 400, 500 patients in it, but I would consider it modest. The investigators did not agree with me, but that's what I feel. What about the pipeline? I mentioned it. We have the chloride homeostasis. We want another study in US is ongoing. They are giving these patients lysine chloride, sodium-free chloride, to see what they see in terms of neurohormonal activation and the ability of the patients to get decongested. So what's my conclusion? The current discrepancies or confusion that we might see in some of the studies regarding the sodium-centric approach that we have might be, in part at least, due to ignoring chloride. Then I would think that chloride may be a stronger prognostic marker in syndromes of heart failure, including the acute or chronic, whether it is with reduced ejection fraction or not. And then, on the practical side, because many of you are intensivists, acetazolamide has a very good safety profile. When you have a patient with lingering congestion, I deal with it with my patients with heart failure quite a bit. The bicarbonate is going up, they are making marginal urine, you don't know what to do with them. It never hurts to give them a touch of acetazolamide. Just please make sure that acetazolamide can give you major kaliuresis. So if a patient has hypokalemia, you want first to replete potassium before starting acetazolamide. And with this, I would like to thank you for your attention.